Hi guys, welcome back to my YouTube channel. My name is Uche Kennedy, and here we prepare people for everything USMLE. We share tips on how to get you the best score possible on your USMLE examinations. Today we are going to begin a new series actually. In this series, what we are going to do is basically take a concept, something people have asked me a lot about during the week, and I'm going to take those and make them into a video. I'm going to explain them because there are a lot of simple things, or at least I would think they are simple things that students ask me about, and I have to explain. For example, in this past week, it has been edema. I've been explaining edema, capillary hydrostatic pressure, capillary oncotic pressure to my students and a number of other people. At least I've explained that concept maybe 10 times in this last week. So I've decided to take that concept and make a video of it and put it out here so everybody else will have it. And then these students can also come back and view these videos and watch these videos when they are ready. If you're new to this channel, please remember to subscribe down below. Give this video a thumbs up, like it, share to someone so that you can help someone else on their journey as well. And if you find them helpful, please let me know. Leave a comment down below. Ask your questions. If enough people ask your question, I'm going to address it. I'm going to make a video explaining it, no matter how long that concept is and no matter how complex it is. A lot of things are actually very, very simple. With that out of the way, let's get into the video. Edema. Let's imagine that this is a blood vessel. Let's take our blood vessel. In here we have blood vessel. There's blood flowing within this blood vessel. This blood flowing in this blood vessel exerts some pressure on the wall of the blood vessel. We call that the capillary hydrostatic pressure. The pressure exerted on the walls of the blood vessel, the capillary, by blood, plasma, whatever they call it, is the capillary hydrostatic pressure. Within this blood vessel, we also have proteins that act in the opposite direction. Like you remember, we have a lot of albumin. That's the most abundant protein produced in the liver. It exerts a pulling force as if to pull fluid into the blood vessel. That is called the capillary oncotic pressure. So this is capillary hydrostatic pressure. Take note, sometimes they are going to write plasma hydrostatic pressure. This is capillary oncotic pressure. Sometimes you're going to hear them say colloid pressure. Colloid osmotic pressure. The same thing, doesn't really matter much, right? So we have one force driving fluid out of the blood vessel, the capillary hydrostatic pressure, and we have one force trying to bring fluid into the blood vessel, the capillary oncotic pressure. Outside of this blood vessel, in this environment where the fluid looks like it's moving to, we have the interstitial space. This is the interstitial space. It is the area around this space where you have all your cells that are going to be bathed in interstitial fluid and lymphatic kind of fluid and all of that. That is the interstitial space. Now, because there's fluid in the interstitial space, the interstitial fluid also exerts its own pressure, just like the capillary hydrostatic pressure, in the opposite direction, as if to push fluid into the blood vessel. So we are going to call this the interstitial hydrostatic pressure. The interstitial hydrostatic pressure. You want to know that the interstitial hydrostatic pressure is almost negligible, like it's not a lot of pressure. And then we have proteins also in this interstitial space. Just like we have albumin in here, we also have proteins in this area. And they have a pulling effect. They pull fluid into the interstitial space. So we are going to call that interstitial oncotic pressure. So now we have interstitial hydrostatic pressure. And interstitial oncotic pressure. Right? We have those forces. How do we know what direction fluid is going to go? The direction fluid is going to go depends on the balance between these forces. So we want to take all the forces that act in one direction. For example, if we take capillary hydrostatic pressure and interstitial oncotic pressure. We are going to have net filtration, capillary hydrostatic pressure, plus interstitial oncotic pressure. And then we contrast them to the forces pulling fluid into the blood vessel, capillary oncotic pressure, and interstitial hydrostatic pressure. So interstitial hydrostatic pressure, oops, this is capillary, I hope the difference is clear. This is interstitial, and capillary oncotic pressure. When we do this, we are going to get our net filtration. Of course, there is a K somewhere there, it doesn't matter, a coefficient of filtration, useless information. You don't need to learn this formula, you don't need to memorize this formula, you just need to understand what exactly is going on. Now, notice, the capillary hydrostatic pressure is the force pushing fluid out of the blood vessel. Is the force pushing fluid out of the blood vessel. What do you think is going to happen if you increase capillary hydrostatic pressure? Then this net filtration will be balanced in this direction, meaning that fluid is going to leave the blood vessel into the interstitial space. If you increase the capillary hydrostatic pressure, then fluid is going to leave the blood vessel into the interstitial space. What are examples of scenarios where you're going to have an increase in capillary hydrostatic pressure? Now, the reason why this is an important concept is because you're going to have this same underlying principle with a lot of disease processes. Let's take our first example. Let's take a patient with heart failure. Let's start with left heart failure. So if I give you a patient with left heart failure, what happens in these patients? The left ventricle stops beating, ejection fraction goes down, right? The heart is not working properly. And then there is backward failure or backup of blood. There's backward failure or there's backup of blood into what part of the body? Into the lungs, right? Now you're going to have increased capillary hydrostatic pressure within the pulmonary vessels. Think of it. So blood backs up from the left ventricle into the left atrium and then into the pulmonary vessels, pulmonary veins. And then when this blood backs up into the lungs, the capillary hydrostatic pressure within the lungs is increased. And as a result, what happens? Fluid leaks out of the blood vessel into lung tissue and causes what? Pulmonary edema. So this is the underlying mechanism for pulmonary edema. Let's consider someone with right heart failure. A person with right heart failure, again, the right is going to have, let's consider backward failure, right? If the right ventricle fails, then the right ventricle is not going to be able to take in blood, therefore blood will back up into the right atrium. If blood backs up into the right atrium, so we have the right ventricle, if it fails, blood backs up into the right atrium and then into the what? Inferior vena cava, for example, and even the superior vena cava as well. And the backing up into the superior vena cava, if you remember, was what produced jugular venous distension, because from the superior vena cava, then it goes ahead into the jugular veins. But let's consider the inferior vena cava for this lesson. When we talk about when blood backs up into the inferior vena cava goes down into the hepatic vein, and then where? Into the liver. When fluid backs up into the liver, what happens? The patient develops hepatomegaly. Why? Because the fluid is not just going to stay confined in the blood vessels, it's going to seep into the parenchyma of the liver. It's going to seep into the tissue of the liver. So again, increased capillary hydrostatic pressure within hepatic vessels eventually would cause hepatomegaly. So that is one spot. You may remember that this hepatomegaly at the point is also described as nutmeg liver. Nutmeg liver. This fluid is going to continue to back up into all the areas where you have veins that drain into the portal system or veins that drain into the liver, including the lower limb. This is how people get pedal edema. How do people get pedal edema? They have fluid backing up to the lower limbs, the fluid accumulates, and then the lower limbs swell, pedal edema. Ascites. What happens in ascites? When people have ascites, blood simply backs up again from the portal system. You may remember the hepatic portal system, we're not in anatomy. Blood drains from the hepatic portal system backwards into the periumbilical veins, right? It drains into the periumbilical veins. And then eventually seeps into the abdominal wall and you get ascites. So what you see is just by having heart failure, we have all of these possible findings that we could get. And they are all following the same underlying principle. There is an increase in capillary hydrostatic pressure resulting in edema. If someone has liver cirrhosis, two mechanisms work in liver disease, but we'll just talk about let's say someone has liver cirrhosis. If you remember, in liver cirrhosis, there's portal hypertension. Portal hypertension will result in backup of fluid, that will result in ascites, that will result in pedal edema, and so on, right? So that will also occur with liver cirrhosis. If you think of a patient with Budd-Chiari syndrome, what you'd notice in patients with Budd-Chiari syndrome is, remember, there's hepatic venous thrombosis to start with. We are not discussing Budd-Chiari syndrome, but we are going to mention a few things, right? Hepatic venous thrombosis. Again, because of this thrombotic material we have in the hepatic vein, blood backs up into the liver, results in hepatomegaly, and then backs up into other parts of the body and causes ascites as well and pedal edema. So notice that with all these differentials, the underlying mechanism is the same. And this is what makes general pathology perhaps the most important aspect, because a lot of the diseases we talk about share a very basic underlying mechanism. The difference is that the nomenclature changes as you go across organ systems, right? So these are examples of where you're going to have an increase in hydrostatic pressure result in edema. The other thing we can do to cause edema is decrease the capillary oncotic pressure. So what if we decrease capillary oncotic pressure? Then fluid will not come into the blood vessel. So let's say albumin, the proteins. So you remember that capillary oncotic pressure depends on proteins, right? It's the proteins that are trying to pull blood into the blood vessels. Now, if for some reason there is no protein in the blood vessel, then you're not going to have fluid coming into the blood vessel because the capillary oncotic pressure will be too low. If you decrease the capillary oncotic pressure, again, you're going to push net filtration to favor this direction. If the capillary oncotic pressure is too low, net filtration will favor the opposite direction. And as a result, again, you have edema. Now, take note, edema occurs usually when fluid accumulates in the interstitial space. Edema occurs usually when fluid accumulates in the interstitial space. Maybe that's something you want to know or remember. Edema occurs when fluid accumulates in this interstitial space, right? One of the mechanisms of that happening is increased capillary hydrostatic pressure. The second is a decrease in oncotic pressure, again, which is going to be as a result of decreased proteins within the blood vessel or decreased albumin within the blood vessel. Then you are going to have to ask yourself, what will decrease capillary oncotic pressure? What will decrease capillary oncotic pressure? We said capillary oncotic pressure depends on proteins, especially albumin. So what would cause your protein level to be low? A possibility is decreased dietary intake. Maybe for some reason, someone is so malnourished because there is no protein in their diet. And it's to the point where it actually decreases their oncotic pressure significantly enough to cause edema to occur. Think of a patient with what? Kwashiorkor. Think of a patient with kwashiorkor. That would be your classic example of decreased dietary intake. These people have decreased protein intake, and that results in decreased oncotic pressure, capillary oncotic pressure, that causes them to have edema. So if you look at every image of those children, you're going to have to see them with their big bellies, right? Something of that nature. The second is maybe because you are not producing enough proteins. So decreased production. Decreased production is going to be in people with liver pathology. So liver cirrhosis now is going to have multiples. It could be a person with cirrhosis or any of the other liver diseases you can think about. If you do this, someone has liver cirrhosis, you're going to decrease albumin, and therefore you're going to decrease capillary oncotic pressure, and that will lead to what? Edema. So we also have edema in liver disease, and you want to know what the different mechanisms are, because although it's all edema, the mechanisms are not quite the same. All right, that's liver cirrhosis. The third reason people will have decreased protein is because they're excreting too many of it, right? So let's say someone has nephrotic syndrome. Nephrotic syndrome. From renal disease, right? Renal pathology. Sometimes they're not going to spell it out to you. They will tell you someone has renal pathology by giving you their creatinine. So they'll have elevated creatinine, elevated BUN. Oftentimes that's the only cue they give you, and then they describe the other features. Because it's a general pathology question, they don't have to necessarily show you all the symptoms of renal failure and spell it out to you. They don't need you to diagnose anything. So nephrotic syndrome with renal pathology, you're going to also have that finding. People are peeing out protein, increased protein excretion. Increased protein excretion. That can also result in edema. If you pee all your protein away, you decrease capillary oncotic pressure. Remember, they could also call this capillary colloid osmotic pressure. Sometimes you're going to see them say colloid osmotic pressure. You want to know what colloid osmotic pressure is? It's the same thing as saying capillary oncotic pressure. If you decrease capillary oncotic pressure, again, you're going to produce edema. Fluid will move out of the cell. So these are the three scenarios that I think are most important for your exam. Think of the child with, what do we call it? Minimal change disease. Very classic one, right? A child with minimal change disease. Remember their puffy eyes and all the additional findings you get in those children. They are all related to what? Nephrotic syndrome, we would say, but fundamentally they are related to decrease in capillary oncotic pressure or capillary colloid osmotic pressure that is resulting in edema. You want to always have that in mind. And then one of the things I would have loved to mention to you about increased hydrostatic pressure. Think of people that have, what's the name? People that have superior vena cava thrombosis, right? Superior vena cava thrombosis. People with superior vena cava thrombosis. Because of thrombosis within the superior vena cava, you're going to have accumulation of fluid. Fluid backs up into the head and neck, the face, and all of that. Again, resulting in edema, right? The third reason someone could have edema is this. We've not mentioned this just yet. Notice that we are having all this fluid either moving into the interstitial space and all. How does the fluid get out of the interstitial space? So if this is blood vessel, let's do this down here maybe. If this is blood vessel, we have fluid seep from the blood vessel into the interstitial space. Does it just stay there? No. From the interstitial space, this fluid is going to be drained or removed via your lymphatics. This fluid will be drained or removed via your lymphatic system. Now, if for any reason there is obstruction to the drainage of this fluid, if for any reason there is obstruction to the drainage of this fluid, then it doesn't matter if your hydrostatic pressure is normal, your capillary oncotic pressure is normal. If you're not draining the interstitial space, then fluid is going to accumulate within the interstitial space. And again, that is going to also cause edema. So the third reason people may have edema, the third reason is going to be lymphatic obstruction. The third reason is going to be lymphatic obstruction. Take, for example, a patient with filariasis. See, or what you'd call elephantiasis. A patient with filariasis, the filaria worm, right? It obstructs the lymphatics and stops lymphatic flow. When you obstruct lymphatic flow, fluid begins to accumulate. So this is the mechanism that causes elephantiasis. Take a patient with breast cancer. This is probably more common on the exam, that is. Take a patient with breast cancer. She underwent surgery. So maybe she had mastectomy and they removed axillary lymph nodes, okay? So let's say axillary nodal excision. So she underwent mastectomy with nodal excision. Now, when they strip the axillary lymph nodes and some lymphatics around the mammary, the breasts, right? What happens oftentimes is that there is stricture. Those lymphatics are going to heal, of course. Now, there'll be no connection between the lymphatics of the upper limb and the lymph nodes within the axillary region. If you don't have, so if you remember how the structure is going to be, let's say this is our woman, this is my woman, this was the other breast, and this one has been cut off. I don't know which woman looks like this, but this is one breast, and this was supposed to be another breast. It has now been cut off. And we used to have these axillary lymph nodes around this area, right? But now we've stripped her of these axillary lymph nodes. So what's going to happen? The lymphatic drainage of the upper limb comes into the axillary lymph nodes, okay? But if we remove these axillary lymph nodes, then there is no drainage for the lymphatics of the upper limb. What happens? Lymphatic fluid begins to accumulate in the upper limb. This is why you may get a question where they would give you a patient that has undergone mastectomy, and now she has swelling of her upper limb. This will usually be in the side where she had the mastectomy, right? On the same side where she had the mastectomy. There'll be swelling of that limb. Why? The reason is because she had lymphatic obstruction. Because she had lymphatic obstruction. So you want to bear that in mind. Think of this. These are the three most important reasons for your step one, why people will have edema. The first is because there is an increase in capillary hydrostatic pressure. So whenever you have a question related to edema, it's usually a general pathology question. You want to bear this in mind. The first is increased capillary hydrostatic pressure. That's the one they test the most. The second is decreased capillary oncotic pressure, rather. Where did I talk about that? Okay. Decreased capillary oncotic pressure as in kwashiorkor and so on, and the liver cirrhosis, nephrotic syndrome. And the third is lymphatic obstruction. Take note of this. Remember, the hydrostatic pressure increases. It doesn't have to be capillary hydrostatic pressure, but now not related to edema. There are other scenarios where hydrostatic pressure increases. Anytime you have backup of fluid in any part of the body, take, for example, a person with hydronephrosis, for example, there is backup of fluid. There is increased hydrostatic pressure within the renal tubules. That's a question on the exam. That's a question they can ask you as well. So you want to bear all of these things in mind. Go do some questions on edema. If you have any other concerns, you don't understand anything here, put it down below in the comments. Put your questions. If there is any particular area you have difficulties with, remember, in this series where I'm actually going to be explaining some basic concepts, I'm going to be answering questions that a lot of persons ask me during the week. A lot of my students, maybe I've had to explain it over and over and over to every single student. So I'll just make a video of it so that they could have it available. And then you all could also have it as well. If you have a question, put your question in the comment. If enough people ask the same question, I'm going to make a video and explain those simple things to you. And I hope this clarifies the concept of edema for you.